First of all, I just want to take a step back and go to what we kind of see in the smaller volume centers, because I need your feedback about this. We see a lot of places that still do not use either a flow inflating bag or your simple neobuff. You still see a lot of places using the self-inflating bag, and we all know that heat is not being delivered. Now, the other challenge is, or something that is not recognized by many centers, that the transfer from the labor and delivery to the NICU sometimes can be done either on a simple nasal cannula or on a face mask, where you're essentially not giving any CPAP as well. So I would like you to comment about that. For Dr. Saad, thank you very much for the presentation. My question is about second dose missed or missed. Now, if the baby within 6 to 12 hours requires a second dose, would you recommend that we intubate or we give a second dose? And another question, I'm sorry to say one more, is when we try to implement these missed initially, there is a lot of worry about the risk of pulmonary hemorrhage. Although pulmonary hemorrhage is known to be reduced actually with Nixan, it's not higher. But a lot of people, including the nursing staff, feel that even if pulmonary hemorrhage occurs as a natural consequence of RDS, that it is a more controlled environment to have the baby intubated anyway. What is your opinion?
So taking the first question about kind of, I would say, level 2 and level 1 units, and in particular the absence of having deep circuits and using self-inflating bags, I think there is good evidence that we should be transitioning onto use of continuous respiratory support. Now, there are self-inflating bags that are able to deliver. I just say that a randomized controlled trial with vaccine, both the self-inflating bag and the TP shows that it's really poorly delivered by the self-inflating bag with beam. It's very variable. This is a simulated model. Hence, I would say that having the ability to use a TPs in those centers for me is quite essential. It needs an element of training, but can be rapidly learned. I think the other important aspect to it is just transfer of preterm babies on face mask. If you're not able to be able to deliver, say, TP space resuscitation, and you have CPAP devices on your neonatal unit, you can adapt humidified CPAP delivery in the delivery suite by actually adding it to your resuscitators. We've done that, and we've basically done that with bubble CPAP, and that can provide PEEP. The challenge there is you will not be able to provide IUPV, so you still need a circuit to be able to provide IUPV. I think for me the importance is about the equipment, but more importantly the training around it. Having some element of delivery of effective PEEP is the most important aspect of it.
Thank you very much for the question, Dr. Talal. Maybe first question, I can maybe I talk about it with the first time I started in one of the hospital, in that hospital, Lisa. I was around 4 o'clock p.m. The patient had 2 weeks in between. These are this intubation. Wallah, is not. I said, okay, let us give survivant through Lisa. Nobody knows in the unit. First, number one, my colleague, the respiratory therapist, said there is no guidelines. He said, okay, I don't want, and our supervisor will, press on us. He said, okay, I don't want to be any problem between you and supervisor. In this case, please don't help me, because I don't want your supervisor to abuse you. The nurses, one of the assistant consultant, and myself. Just when you start to prepare, I see that their supervisor standing there. And while we are preparing, said, Dr. Saadi, you did absent of us? I said, no. But there was, they said, no guidelines, the patient needed. So we gave the first surfactant. Even their supervisor was observing with us. The problem is to answer your second question. He's due for second dose of surfactant at 2 o'clock in the morning. Still, you require some oxygen, but not enough to intubate. Now there is another assistant who has no experience with it. I have to come from home, drive 25 minutes to give the second dose of Sema. So you can use it. If you look at the literature, there is no agreement and one really controversy when you use a second, should you use it for a second or not. Regarding the intracortical hemorrhage, it's multifactorial. We know it's going to happen. But for example, we will document that fluctuation of steroid blood flow is one of the causes, and this is associated with intubation. Sometimes intubation you cannot avoid it. You have to. But sometimes indirectly you can avoid it. But there is multifactorial is not should be in every patient. There is some predisposing factor. If you can work with this predisposing factor, you do your best. I think that's better. Does this answer your question, Dr. Alan?
Was about pulmonary.
Oh, sorry, I talk about IVH.
Pulmonary.
Pulmonary hemorrhage, my opinion is not about it. I agree with the state. If it's going to happen, it's going to happen. Except if there is a predisposing factor like BDA and other significant BDA.
Coagulation.
This is maybe one of
Risk
the
factor preliminary.
preventable factors. This is going to happen, it will happen, you agree with me?
Yes, I think for me, giving the second dose of surfactant, depending on the clinical status of the baby in freezer, comes back to the question, were we right to have given these in the first situation? Would we have considered doing a tube? And a simple example that I'll give you is I have a baby who's had no antenatal steroids at 26 weeks, who's needed extensive resuscitation in theatre, but is reasonably stable. Now again, that's a baby who's very high risk, and I think a tube with surfactant would be the better of the two evils in that situation. In terms of babies who need a second dose of surfactant after Pisa, is it the RDS, is it pulmonary hypertension, and making that assessment is quite crucial. Is it a pneumothorax? And can I just say that I've had a lot of babies who've developed subtle pneumothoraxes after Pisa. Now they still have a high FiO2 and they have a high worker bleeding. And actually giving surfactant there may or may not be the treatment. It might be drainage of the pneumothorax. Lung ultrasound can help. It may, and before giving a second dose, we always do lung ultrasounds in babies. Exclude a surfactant. Again, if you're kind of in a situation where this is a high FiO2, but CO2 clearance is okay, the question at this particular point is this more pulmonary hypertension than just pure RDS? So I think the clinical judgment around that becomes quite essential in those circumstances. I think a reflex kind of giving the second dose of surfactant without having made that evaluation might not treat every cause. Pulmonary hemorrhage, once the PVR is dropped, it is a high risk. Again, maintaining an effective PEEP, making sure that we keep the seal. And a simple example is sometimes the nurses have not noticed and the CPAP is off and the mask is off. And that's a big risk because your PVR is low and then there's a higher risk that this baby might have an hemorrhage in those circumstances. So, no right or wrong answer, but yeah.
I think time is about. We have one question, Dr.